It's right on time. Hello and welcome to the ASLM special COVID-19 session number 9, a series which we have dedicated to diagnostics in the COVID-19 pandemic response. Today we are focusing on the knowledge gaps and updates on the updates on performance and serology of serology tests. My name is Anafi from ASLM, where I serve and contribute to our efforts in the acceleration and adoption, as well as integration of innovative diagnostics into national programs funded by UNITAID, together with our efforts in the laboratory systems strengthening community of practice funded by the Bill and Melinda Gates Foundation. I'll be your moderator today. It will be a 1-hour-long session, and we shall have 2 presentations followed by a question and answer segment. You are reminded to enter your questions and comments into the chat box. So today's discussion, serologic diagnostic testing, a hot topic indeed these days, has been proposed to be very useful in combination with molecular testing, particularly confirming COVID-19 infections and exposure to the virus. Serology tests also have the potential to be delivered in a rapid format and at the point of care, and could contribute immensely, as well as guide appropriate patient management and public health measures. To date, hundreds of companies have claimed to be developing, or actually in the process of developing, the SARS-CoV-2 serology tests. Just about 2 weeks ago, we were here on this platform where we discussed the potential role of serology tests in the pandemic response. Today, we are going to continue that discussion, looking at what is known and what are the remaining gaps regarding the actual performance and clinical utility of these tests. We have lined up 2 experienced researchers in the name Professor Rosanna Peeling, who is the chair of the Diagnostics Research Centre, as well as the director at the International Diagnostics Centre of the London School of Hygiene and Tropical Medicine, as well as Dr Jilian Sacks, who is the Senior Scientific Officer for Pandemic Preparedness at the Foundation for Innovative New Diagnostics, FIND. I'm going to hand over to Prof. Peeling to take us through the first presentation. Over to you, Prof. Rosanna?
Yes, I'm trying to share my screen, but it doesn't allow me to for some reason. Oh, okay, great.
Thank you.
Hello, everyone. Today, before Jillian gives the performance of tests that we have been looking forward to so far, I'm just going to go over with you some basic principles of how we express performance characteristics of diagnostic tests. How do we do evaluations, and also looking at what are the differences between an evaluation, a validation, and a verification of diagnostic tests and their operational performance characteristics, and how do we select diagnostic tests. So to begin with, this will be very basic information to some of you, so bear with me. The most common way that we express basic performance characteristics of a test is for infectious diseases, is to try to distinguish between those who are infected from those who are uninfected in a population. So if you look at the figure, all the ones in blue are the ones who in the population that are uninfected, and the ones with the little pill with the red and white color represent the ones that we say are infected and require treatment. So a sensitivity that we use to express characteristics of the test is a probability that a truly infected individual would test positive when you use it in that population. And so that's identifying all the ones in the population who have a little red and white pill in its figure. And specificity is the probability that a truly uninfected individual would test negative. And that's the ability of the test to identify all the people who are only in blue in this figure. And so sensitivity and specificities are usually determined against a reference standard, which we sometimes call a gold standard. And it represents the true value of what's being measured. But quite often we don't know what the reference standard is, or that in this case of when we have a new disease like COVID-19, we actually don't have a true gold standard. So we use what we can develop as a reference standard, and then try to obtain international consensus to use that as a reference standard. So when you have, how do you measure sensitivity? So if you define sensitivity as ability of a test to correctly identify an infected individual, then we could use this formula of the number of positives measured by the tests under evaluation over the number of positives measured by the reference standard. So the formula is A over A plus C times 100, and that would give you the percentage, sensitivity percentage. And similarly for specificity, you can use a number of positives identified by the test under evaluation over the number of negatives that are identified by the reference standard times 100, and that gives you specificity. Now, these values of sensitivity and specificities are inherent characteristics of a test, and they don't really change. But in terms of clinical decision-making, what's very valuable to clinicians is the positive. Just at the point of saying that a positive predictive value is the probability that those testing positive by the test are truly infected. So that's of value to a clinician trying to make a decision on what the test results mean. A negative predictive value is the probability that those testing negative by the test are truly uninfected. Now, while sensitivity and specificity are characteristics of the tests themselves, and they don't change, predictive values also depends on the prevalence of infection in the population. And so choosing to use a test in a high prevalence situation would give you a high positive predictive value. So here I illustrate on here with example from a study of fever patients in Burkina Faso. So the study investigator wanted to know, in the population of patients presenting for care with fever, how many of them are due to malaria. So he used a malaria rapid test, and in rainy season, 443 out of 650 patients test positive for malaria. But in that same population, in dry season, only 113 patients out of 400 tested positive for malaria using the same RDT. And so if you look at that, in rainy season, when malaria transmission is high, the rapid test predictive value, positive predictive value, range from 38% for adults to 82% for infants in that population, while the negative predictive value range from 84%.
Looks like we have lost Rosanna again. Just search here. I can see here. Rosanna, are you there?
Yes, I am here, but I somehow, the screen sharing didn't work. So
you can try to share again. I've made you as co-host.
Okay. So can you hear me now?
Yes, we can hear you.
Okay. So during the dry season, the malaria transmission is low. And so that same rapid test has a lower positive predictive value of only 9% for the population, with a negative predictive value of over 99% for fever attributed to malaria. So you could see that even though with the same test, when you have high prevalence of infection, the predictive values would change versus a low prevalence of infection. So how do you calculate positive predictive value? So here is the formula: number of true positives over the number of true positives and false positives gives you the predictive value. And the negative predictive value is given by the number of true negatives measured by the tests under evaluation over the number of true positives, true negatives, plus the number of false negatives. So with that, I just want to say that for diagnostic evaluations, we have different types of evaluations depending on the purpose. So when we first have a test, we like to evaluate in a lab what is the true characteristics of the test in terms of the ability to measure and analyte correctly and reliably. So an analyte is anything of interest that you want to measure, such as in COVID, we want to measure the antibody response, for example, accurately and reliably. So we would use well-characterized samples that we already know, for example, through other means of validating that they are from patients who are maybe RT-PCR confirmed to be COVID positive, and then we follow them out and take a blood sample 7 days post-infection, 14 days post-infection, and see if they have antibodies. And if they do, then those could become well-characterized samples that you use to try to measure different tests that are that you are trying to evaluate how good they are. And those types of lab evaluations give you analytical sensitivity and specificity. And you could also measure how reproducible those tests are. And I'll talk a little bit more about that later. Now, that gives you the performance of the test in the best hands under the best conditions in the lab. Now, of course, these, if they are rapid tests, you want to be using them in the field, then you would take them out to the setting of intended use and use it on consecutive patient samples coming in for care, and you measure their ability to detect positives and negatives for clinical decision-making purposes. And you could, at the same time, measure how robust they are under field conditions, whether parts of it break down, whether the reagents are stable at the temperature in the clinics, and also the feasibility that the people in the clinics have the ability to do them well. And so that's a field evaluation, and that gives you the clinical sensitivity and specificity. And as you measure them in a defined population using consecutive patient samples, you could also calculate the positive and negative predicted values. Now, finally, a very useful type of evaluation are the clinical utility studies. And this is really for looking at the balance of risks and benefit associated with using a test for the patient as well as for the control program. So you usually measure health outcomes, but you try to measure, if you're evaluating several tests, how cost effective they are, which one is the most cost effective. And also you could do other type of implementation research, such as changing patient pathways to make it more efficient. Now that you have a rapid test, you don't have to make an extra appointment for patients to come back for their test results. They could wait for the results right there and then. You could look at whether, linkage to care is good, and also if there's data connectivity, you could actually use that data to map the progress that a pathogen is making in an epidemic across the country. So those are clinical utility studies. And I just want to say a little bit about both the clinical utility studies and the clinical evaluation studies. You often see those values of sensitivity and specificity with a bracket looking at confidence intervals. So a confidence interval allows you to know the bounds within which you could be very sure of the point estimates of sensitivity and specificity. And increasing the sample size of the evaluation usually it reduces the uncertainty around the point estimates of sensitivity and specificity. And so we normally choose a 5% interval so that you have what we usually call a 95% confidence interval. And that means that within those bounds, you can be 95% confident that the interval contains the two values of sensitivity and specificity. And so the sample size actually contributes to how robust that measure of performance is. And so, and you could calculate this with very complicated formula, but just for the ease of reference, so put in here a table where if you estimate that the test under evaluation has a sensitivity of or specificity of 90%, for example, and you want a confidence interval of 95%, then if you look over to the number of subjects required for the evaluation, you'll see that it's 150. And so, and so you could use a formula to calculate the sample size you need for the evaluation. Now, I want to take you through different concepts of performance evaluation, validation, and verification. So when a test is being evaluated, you are undergoing a process of determining how good the test is. And the sample size would vary depending on the type of evaluation. For example, in the lab, when you're trying to establish whether the test detects the analyte of interest, you could probably use less than 100 samples. But in a clinic-based evaluation, as you saw from the table just now, if you think your test has 90% sensitivity or specificity, and you want a confidence interval of 95%, you need at least 150 positives and 150 negatives in order to be able to establish accurately the point estimates of sensitivity and specificity. So in that case, you need at least 300 patients, but of course not all patients will consent to being included in an evaluation study. So you usually factor in the percentage of people who may decline, which may be another 10%. So you usually need around 400 or 500 patients in order to be able to evaluate, do a clinic-based evaluation. But of course, it also depends on the prevalence of infection in that setting. Now, in terms of utility studies, because you're trying to study many different factors, those could be very big studies, but you could also use a very well-defined sample size and model the outcomes. So those are evaluations when you're trying to find out how good these tests are. Now, in terms of a validation, usually this applies to lab-based assays. For example, with COVID, and you're trying to establish whether the primers and probes that you saw published on the WHO website, for example, for the Berlin Protocol or for the CDC protocol, and you measure, you order some primers and probes, and they came, you want to be able to use a process to validate, in fact, that these reagents used on a strain that you know to be the SARS-CoV number 2, that you would be able to detect the viral RNA for these samples. And so this would be a process of validating the test before you use on patient samples. Now, verification means that when when you already know the performance of the test from evaluations that's been done, for example, by FIND or by WHO pre-qualification or by something that you've read in the literature and know that the study is robust, has all the right sample size, the right reference standards, and is similar to the setting at which you want to use the test. When you order the test and they arrive in your lab, you don't need to do the full-blown evaluation all over again. And so what you do is something called verification to know that with a small sample, you want to repeat the accuracy, which is the concordance of positives and negatives. And typically we use about 20 positives and 10 negatives. And you want to establish the precision, which means that the assay does not vary from operator to operator, from site to site and day to day. And so you would measure, use 10 samples for each one of these parameters. And if it's a quantitative test, you would want to look at the reference ranges and the reportable ranges, which you will find in the product insert of the product. So it's not required that you do a full-blown evaluation. All you need to do is a verification that the test that you've ordered in fact fulfill the kind of performance characteristics and operational characteristics that are that the manufacturers have claimed, or that WHO pre-qualification or FIND have found on these products. With regard to number of samples that you want to use for reproducibility and repeatability, there's no real hard and fast rule, but in general, when we say reproducibility, we want to know that when the conditions of testing changes, for example, when you change an operator, when you change the geographic location of where you use the test, or you use different instruments from the same company and different test lots. So for example, if you use one lot now, and when you run out, you order another lot, is there a lot-to-lot variation? And usually these can be performed using a minimum sample of 10 different specimens, including some positive and negative controls. And you try it on different operators to see whether they get the same answers at different sites or on different days at each site. Now, repeatability of a test result refers to measuring the closeness of the results when no conditions of measurement changes. For example, with the same operator, you have the person test 3 different samples, a positive, or 2 positives and a negative, and you ask them to repeat it 6 times for each sample to know whether you get exactly the same result. So those are the kinds of measurements that you could do with each test. Now, finally, in selecting a diagnostic test, we usually, this is taken from a paper that was published in the bulletin of the WHO by Kolsak and al. And there are 6 steps to the selection of a diagnostic test. You want to define the test purpose first, which means why are you doing it, what are you doing, where, and who would perform the test. And depending on those answers to those questions, you need to choose the test with the appropriate format. For example, it would be different if you were in a lab versus if you're in the field where there's no trained lab technicians to do the test, what test would you use, etc. And then you review the market to see what tests are commercially available. And then you also review that in your country has regulatory approval by either an international body or in your country, the national regulatory body, has it approved the test for use and for what use. And then you determine the test's optimal diagnostic accuracy. And we've talked about those in terms of sensitivity, specificity, and then determine the test's diagnostic accuracy in practice, which we said is the field performance, the field evaluation or clinic-based evaluation that we mentioned. And then finally, you want to monitor the test in routine use to know, one, that technically is feasible to do, and that you could do it with assurance of quality and of both the test and the testing. And so in this respect, the thermal stability of a test in a field setting is quite important as well. So now, I just want to flag that in terms of COVID, there's been a lot of talk about not using antibody tests in a general population. And here's an illustration of why. So if a test for COVID is 98% specific, which in general we think it's pretty good, but if you look at 100 tests, there will be 2 false positive results. Now, if the prevalence of COVID in the general population is 50%, 100 tests will give you 50 true positives and 2 false positive results. And that's a pretty good positive predictive value of 96%. But if the prevalence of COVID is only 1% in your population, then 100 tests will give you 1 true positive for every 2 false positive results that you get, which is a very low positive predictive value of 33%. So it's very important to know approximately the prevalence of infection before you say whether a test of 98% specificity is good enough, for example. So that's the kind of consideration that should go into how you select a test for the right purpose, in the right population, for the right patients as well. So finally, I want to summarize by saying that sensitivity and specificity are the most common ways that we measure the performance of a test. And these are inherent characteristics of a test. The positive and negative predictive values can vary by prevalence in the population, and those values are of really importance to clinical decision making. The evaluation of test performance can be affected by what type of reference standard you use, whether it's the correct one or not, the sample size, and whether it's appropriately evaluated in that population. There's a distinction between evaluation, validation, and verification, and they should be carried out in appropriate circumstances and not duplicated. Quite often we find that even though a test has been WHO pre-qualified, countries are still trying to do full-blown evaluations when there's no need to do that. All you need to do is use about 40 samples to do a verification of the test when it arrives in your country. Finally, the criteria for selecting a diagnostic test should take into account how the test will be used, in what settings, by whom, and the accuracy of the test performance, the feasibility, and the ability to assure quality of tests and testing. Now, what we haven't discussed, of course, is the final bottom line, which is the criteria for choosing a diagnostic test quite often has to take into account the cost of it. So I like to conclude by saying that no test is perfect. So we always try to balance between the trade-off between affordability, accessibility, how many people you could test, and accuracy. And the 3 A's are what you should keep in mind when you're selecting a diagnostic test. So thank you very much.
Thank you very much, Rosanna, for the very educative presentation. Colleagues, we will jump straight into the second presentation from Dr. Jilian Sacks from FIND, who is the Senior Scientific Officer in Pandemic Preparedness. Jilian, over to you.
Great. Thanks, Anafi. I hope you can see my screen. So I'll try to go as quickly as possible since I know we're running a bit behind. So to follow up on Rosanna's excellent coverage of how to assess a test overall, its performance, I'd like to then bring this specifically to COVID and think about how we would think about performance when selecting tests and why we actually are testing. So I just want to give a bit of background here, saying that when we test for COVID right now, depending on your country context and whether you have ongoing community transmission or you have sporadic cases, clusters of cases, the goal of testing might vary. So if you're trying to stop transmission and prevent spread, or whether you're trying to just slow down transmission, reduce health, social, and economic impacts, etc., you might select different testing modalities. But overall, you're going to be testing for two different things. One is testing individuals who are actively infected with the disease, and then testing individuals who had previous exposure to the disease. So who should be tested? Right now, we should use clinical symptoms as well as epidemiological factors to ascertain the likelihood of infection. And PCR really is the gold standard testing for infection, and especially if you're going to be testing asymptomatic or mildly symptomatic individuals. I will say overall, and I'll get to this a little bit later in the presentation, there's very little data on the accuracy of antibody tests or antigen tests in asymptomatic or mildly symptomatic individuals. But because we know PCR testing access is very limited right now, we also need mechanisms to rapidly collect and test patients who meet suspect case definitions, as well as to test individuals who may have had previous exposure. And so we really want to think about what the utility of a point of care test or a rapid test format would be. This is a bit text heavy, but I'd like to just review a few unique features of SARS-CoV-2 that need to be considered when we're using RDTs for diagnosis or for testing of exposure. So it is a respiratory pathogen, which is unlike HIV or dengue or Zika or chikungunya, which are bloodborne viruses. Data is emerging that the immune response to SARS-CoV-2 is atypical, whereas for other viruses, IgM is often detectable in the blood during active infection and then wanes, followed by IgG levels rising. This doesn't seem to necessarily be the paradigm for SARS-CoV-2. And I think Professor Peeling reviewed this in her previous webinar a few weeks ago. It's also important to note that there may be very high levels of virus days before onset of symptoms. It's estimated that it's a wide range, but between 6 and 44% of transmission may be occurring before symptom onset. And as I already noted, we don't have a lot of data on the performance of tests for these asymptomatic individuals, so that needs to be considered. And then I think the context really also needs to be addressed. So in a pandemic situation, where we have no specific treatments and the goal is really to minimize spread of the infection, we need to select tests that have the highest possible sensitivity to ensure that we're not missing any cases. This also can help to reduce the burden on confirmatory testing in the setting in which you don't have access to PCR because of shortage of reagents or perhaps challenges with transport systems, etc. In this context, a pandemic situation, all individuals who screen positive could be directed to home isolate, be admitted to a healthcare facility if they have symptoms without the need for a confirmatory test. But as we know that prevalence in most populations will actually be low, and as Professor Peeling just reviewed, the specificity is also critical to ensure a high positive predictive value because you don't want to inappropriately direct people to home isolate. So what do we know about SARS-CoV-2 antibodies, since that's the focus of our topic today? So antibody tests obviously detect the host response to the infection, not the infection itself. It takes several days for your immune system to develop an antibody response to an infection. So likely antibody tests are really going to be most accurate at least 10 days post-infection. These antibody tests can target various proteins of the virus. Several of the currently available rapid tests, which I'll go over later, target the nucleocapsid protein, which is very abundant. It's highly immunogenic, so there's a lot of antibodies directed towards it, but it's internal to the virus, so it's very unlikely that any of these antibodies are actually neutralizing, which is what you need for protection. It's also very relatively conserved across other coronaviruses, and so there may be cross-reactivity between tests that target the N protein of SARS-CoV-2 and other coronaviruses. There's also antibody tests that target the spike protein of the virus, which is responsible for viral entry into the host cell. And so likely when looking for neutralizing antibodies that could offer a protective response, antibodies that target the spike protein are probably the best bet. Just to highlight that antibody tests cannot distinguish between active and previous infection on their own. And they cannot currently confirm any sort of immunity to reinfection. We don't have enough data to know how protective the antibody response is to this virus. So given all of this background, I think it's safe to say that antibodies are certainly the best biomarker to estimate the number of people previously infected. And this is really critical to enable more accurate estimates of case fatality rates. You could do serial sampling to enable estimates of incidence, as well as prevalence estimates, which can then help inform testing strategies, as well as enable programs to target populations at higher risk. So what do we know about the products available? So FIND is actively updating our pipeline of antibody tests on our website. And I just pulled this summary from the data as of yesterday. Right now we have listed 159 different rapid tests that target either antibodies or antigen of SARS-CoV-2 from 128 different companies. there's 90 different manual or automated immunoassays from 50 different companies. And if you look at what the targets of these different immunoassays are, the majority of rapid tests have been developed to detect the host IgM or IgG antibodies. The ELISAs or automated immunoassays mostly detect one of the isotypes, either IgG, IgM, or a combination thereof. And then, as I reviewed previously, the target antigen that is being detected by these antibodies is mostly for the N protein. So a lot of these first stage tests will probably not detect neutralizing antibodies. So what do we know about performance? I'll go through a series of slides now to share some information. So the US Food and Drug Administration has granted emergency use authorization to several serology tests, which are listed here. On their website, which is copied below, you can download the instructions for use for each of these tests, as well as the data that was submitted by the supplier to verify the performance of the product. The majority of these tests are automated immunoassays, and there are a few rapid diagnostic tests. And for a test to be approved by the US FDA for emergency use, the test had to meet 90% sensitivity and 95% specificity. So I've just pulled here the performance data that is on the FDA website. What you can see is most of this data was actually generated by the suppliers themselves, but the US FDA is now working in partnership with the National Cancer Institute in the US, as well as BARDA, to conduct independent performance validation studies. And the first product that they evaluated was the Euroimmune IgG ELISA, which was shown to have 90% sensitivity and 100% specificity. The samples that were used for this verification process were PCR positive samples, as well as historic unexposed controls for the negatives. And you can see the, I don't know if you have a pointer. Yeah, you can see that the number of samples is relatively low, and so this confidence interval is quite high. We expect that there will be more data coming out through the NCI initiative verifying the performance of additional tests. I think, though, the trend is quite clear that the majority of antibody tests that are currently approved in the US have relatively high specificity, and with the types of samples that were used for these performance evaluations have relatively high sensitivity. But I think this should be interpreted with caution, and I'll show you a little bit more data as to why. So there's recently been a project called the COVID Diagnostics project, which is a collaboration of multiple groups. And a couple weeks ago, they released their first evaluations of several rapid diagnostic tests, as well as a few ELISAs. They had a sample panel of, as shown here, of different positives and negative samples. And what they've done very nicely is shown through these heat maps, the percent positive agreement between the rapid test or the ELISA and the PCR condition. And this was subset according to days from symptom onset. And what you can appreciate is that the shading gets darker the farther out you go. So the more positive samples can be detected the further from days since symptom onset. So when you pull all of this data together across the multiple products, the seropositive detection increased over time, peaking at greater than 20 days after symptom onset. So that needs to be really factored in when you consider how to use these antibody tests. Across the board, the specificity was also relatively high. And so the final bit of information that I'll present on about what we know about performance of these tests comes from some efforts that FIND is doing, where we are systematically reviewing publications as well as preprints that are available online. And we also have an open call for researchers and laboratories who are doing their own performance validations or verifications on commercially available assays to share their data with us. So thus far, we have data from 44 studies across 15 countries. 19 were pulled from published or preprint literature, and then 25 submissions were directly by different researchers, some of whose logos are listed here. We are trying to compile data across not just antibody detecting assays, but antigen as well as molecular. I will say that the majority of tests that have been evaluated have only been evaluated by maybe 1 or 2 sites, and generally the number of samples tested is quite low. This is just a high-level summary of all the data that we currently have on the antibody tests. And if we do a meta-analysis of the sensitivity, you can see that overall the sensitivity is about 65%, and the overall specificity across all different tests that have been analyzed is around 90%. But again, if we subset this according to days from symptom onset, this is probably a little bit more informative. And you can see that in the early time from symptom onset, the performance estimate is quite low, but then that increases over time. And as I said, sample sizes are quite small, but I think trends are becoming quite consistent. An additional limitation from some of the data that's initially being generated is that the specificity results are mostly on samples from healthy controls of limited geographic diversity. So a lot of the studies are coming out of China or Europe. And so samples with antibodies to various other endemic infections have not been very adequately analyzed. So to address some of this, FIND is conducting limited performance evaluations of molecular tests as well as immunoassays, including the antibody tests. So the goal here really is to try to inform the most diverse approach for countries to be able to make procurement decisions. So we're trying to evaluate as many products as we can. Right now, we are currently evaluating 26 different antibody rapid tests and 7 different antibody ELISAs. We expect to be able to share data by the end of this month, if not sooner. So I'll just briefly review, since Professor Peeling explained different study designs, just what our study design is currently. The antibody tests are being evaluated using a retrospective multi-center design. We have study sites across many continents, although we are definitely needing some collaborators, especially in Africa and Asia. I wanted to just highlight what the use case of these antibody tests are. They are to detect serostatus to determine exposure. And then how you decide to use that information will vary. Some countries might decide to use that to triage COVID suspected patients, although I think there's a lot of data out there that can explain why that might be a limited use case. It can also aid in the diagnosis of COVID suspected patients. So there's the option to combine a molecular test as well as serological status as you're assessing a person and their likelihood of having COVID, as well as potentially assessing recovery in patients who were diagnosed with COVID and are now controlling their infection. This is just the sample sizes that we're using and our reference method. And again, this summarizes the timelines that we're hoping to adhere to. So I know I went through that quite quickly, but I wanted to make sure there was enough time for questions. So just to summarize, no test is perfect, as Professor Peeling explained. Every test will return some positives and some false negatives. And so we really need to consider how we're using the test and not just the point estimates of sensitivity and specificity. So I've just shown here some examples of maybe some expected prevalence ranges, depending on the target population that you plan to screen. I would also say that these are probably on the higher end of the prevalence estimates. So to conclude, when we think about the timing of antibody expression as well as the expected prevalence in populations being screened, it's really probably unlikely to be beneficial to use serology tests to screen for active infection, as your positive predictive value will remain very low. But in order to more appropriately plan public health measures and understand chains of transmission, it will really be critical to define prevalence, and therefore the use of serology tests to screen for exposure, i.e. screening people who've been exposed more than 10 days previously, will be quite beneficial. And obviously you want to select a test that will have a high positive predictive value. We know that tests are rapidly becoming available, and their accuracy to specifically detect antibodies is being assessed, but we also need more basic research to understand the correlation between the detection of antibodies and actually whether those antibodies are protective, which could then enable countries to better plan how to reopen up again. So with that, I will thank you for your attention and open it up for questions.
Thank you very much, Jillian, for the very informative presentation. It is quite impressive to see that most of these kits, the ones that you have mentioned, they are quite good indeed, with high specificities and sensitivities. Importantly, I think the timing of testing will be important. Now we move to questions and answers. As usual, quite a lot of questions indeed. So I'll take a couple of questions from the chat box. Let me take the first one from Stanley Bulime. And Stanley says, it sounds like antibody detection tests would be more useful in quarantine settings because their negative predictive value is low in the early phase post-infection. Prof. And Jillian.
Sorry, Anavi, could you repeat the question? I think I only heard part of it.
Okay. So Stanley says, it sounds like antibody tests would be more useful in quarantine settings because their negative predictive values are low in the early phase post-infection. Any comments?
Yes, I think, and Jillian has data to show that early in infection, within the first 7 days of onset of symptoms, you won't really have much of a detectable antibody response, right? Jillian?
Yep, I would agree.
All right. The next question is from Amuha, and he says, timely diagnosis and scale up in the light of COVID-19 is critical globally. What is the likelihood of having reliable serology tests with antigen detection capacity? Are there any other DTs being manufactured in Africa? Partially touching the last question as well, but you can go ahead and comment.
So I can briefly say there are several commercially available antigen detection rapid tests. The initial data that there's been, I think, 2 small studies published, and the performance of those tests, the sensitivity is really more in the 70% range. And so I don't think that this initial rollout of tests may be sufficient. We know that there's a lot of products under development as well, and we are currently evaluating 5 antigen rapid tests and hope to have results available by the end of May for 2 to 3 of those products. So I think eventually antigen rapid tests could be very useful. But I think until we are confident in their sensitivity, they may have limited value. Professor Peeling, do you have more to add?
Yes, and I recently read another paper where the antigen detection test is only 57–58% sensitive compared to PCR. in which case it, you know, I really doubt that we could use them as they are right now. And I do know many companies are trying to improve the sensitivity of detection, which may require a reader to amplify the signal. And so we may have RDTs that have a small reader that comes with it, maybe in a few months. Over.
Thank you both. Next question is from Mercy Oluya, and she says, where does WHO pre-qualification, FDA approval, CE markings come to play?
Jillian, I think you're better placed to answer.
Please clarify on that one.
Many different countries have their national regulatory authority agencies that are emergency authorizing the use of these tests. And I think that's very critical, but the majority of these approvals are based on data that's directly submitted by the supplier. And the goal is to approve tests quickly so that more data can be generated. So the WHO pre-qualification program does have an emergency use listing procedure for serology tests that is open right now. I don't believe any products have been approved through that process yet. But again, the process itself will review the data submitted by the supplier and will also review, I think for WHOPQ, the manufacturing quality of the company, but there's no independent verification of the performance of the tests. So I think it's a first step, and it can indicate that a product might meet certain standards, but it may not be sufficient for you to feel comfortable rolling it out in your own country. Professor Peeling, do you have other to add there?
Yeah, I think the problem in many national regulatory authorities would like to be able to validate some of the performance claims by manufacturers, but all of us are, you know, in need of good, well-characterized samples. And those are really in short supply. So that's why an initiative like FINDS for everyone to share data would be very useful. Over.
Thank you. Another question, in an emergency like COVID-19, can we take less than 95% confidence interval for potential tests to be used? I think you wanted to talk about, sensitivities and specificity.
Yeah, I think that when we when we encounter a new pathogen, we usually don't really know what's a true gold standard, or even have a reference standard that we all agree to, and so I think it's a bit by bit, we at first would have wider confidence intervals as everybody shares data, but gradually there will be a consensus on what we could use as a true reference test. And I think some of the data that Jillian has shown in terms of sensitivity and specificity of the RDTs really shows that there's a wide variation right now, and some of the confidence intervals are very, very wide. But over time, I think we could learn from all these and be able to come up with something that we could gradually refine and optimize in terms of confidence intervals. Over.
Thank you both again. I'll take the next question from Vini Kamau, and he or she says, thanks, Rosanna. In case you want to validate an assay, not knowing the sensitivity and specificity, can you reverse the calculation? That's the first one, and use a sample size and assume the sensitivity you would have predicted. That's clear.
Yeah, that's often the case with the test that's developed against a new pathogen is we really don't know. And so we usually assume that is somewhere between sensitivity of between 50 to 80%, and then calculate the sample size based on that, which means requiring quite a big sample size. And then as you do more testing, you realize that you could then reduce the sample size, and that's all we could do in the case of COVID, because I mean we're only 120 some days since we first heard about the pathogen. So there's a lot we don't know about the immune response, and so what we're seeing may quite often is hard to tell whether it is the test performance that's good or bad, or whether this is the way the immune response is, right? And so time would help us do all that. Actually, while I have the mic, and Nafi, could I just answer one question that I saw from the chat box quite early on? And that's the use of antibody tests for screening at airports. Now, if we think about using rapid tests on anybody who arrives from a plane anywhere at an airport, we could presume that that's even in this pandemic situation, if you use it on everyone who arrives, then you're testing in a very low prevalence situation, and you will be prone to a lot of false positives over real positives. But if at the airport you have one of those sensors for detecting people with fever, and you only test those who have fever, then you've enriched for the possibility that within those people who arrive at the airport with fever, they're in a pandemic situation. There's a high likelihood that their fever may be due to COVID. And so then if you use antibody tests to see if those people are indeed positive, then you have a better predictive value. Okay, so that's, I think it's useful to sort out. Thank you.
Thank you, Rosanna. I think that's very important. The population of interest will be key. And that links us to the next question from Ramatu Ture. He flips it a bit and goes to when we have a lot of RDTs in the country and we want to evaluate them, with the low prevalence of 1 to 2%, how many samples, positive and negative, do we need? It speaks, I think, to the earlier presentation you made.
Mm-hmm. Yeah. So I think it's a lot of detail to go through, but if you can send your email, we could actually send you the papers that have been published. It's published in Nature Reviews Microbiology, and we've had a series of supplements with Nature that looks at how to evaluate tests, and we've done it for first for malaria, and then for sexually transmitted infections, for dengue, etc. And in each supplement, we go over the general principles of how why we need to evaluate tests. We go over the general principles of how you evaluate tests, how do you calculate sample size, how do you find the gold standard, etc. And so all that information are in those articles. Maybe I would just make the link available, because they are those general underlying principles of how you do evaluations are repeated with every supplement that we published, and so I think that would be something that we could refer to. Yeah.
Thank you, Rosanna. The next question from Jinao. Jillian, you touched on this in one of your last few slides. I think it's important for us to go back to it again. And she says, is there some data on durability of antibody responses to SARS-CoV-2? How long after onset of symptoms can RDTs or ELISAs be used for serosurveys?
Great. So there is emerging data that the antibodies last quite a long time. So I think the big question is, when those antibodies are detectable, do they actually protect you from reinfection? So I don't think you need to be too concerned about the waning response, at least given the newness of this infection. But I think what you do need to wonder about is whether the antibodies that you're detecting are actually protective. So there is some data on time series of how long the antibodies are detectable. Professor Peeling, do you have more to add?
Yeah, I think we've seen in some of the studies that came out of China that within in some of the studies, as much as 30-some% of patient populations have detectable antibody, even within the first 7 days after onset of symptoms. I must say the date of onset of symptoms is may have a recall bias, and because some of them have very mild infections, so they may not recall accurately the exact date of onset. So that's to be taken with a grain of salt. But I think the general consensus from many studies from different parts of the world is that the significant antibody response starts from day 7 onwards, and seroconversion usually meaning that you have a more than 4-fold rise in antibody responses. That usually takes place within the 2nd or the 3rd week after exposure. And so antibody tests are useful during that period. Yeah.
Thank you.
And of course, we don't know enough yet about the persistence of different antibodies or what is protective. Yeah.
Great. Maybe another additional question from Beatrice Lopez, who's from CDC Central America, Guatemala. Thank you for joining. Are you aware of cross-reactivity with dengue? Since dengue is very common in some of these countries, this can be represented as a challenge to interpret results.
From some of the evaluations I've seen, there isn't any cross-reactivity to dengue that was detectable that we know of but the sample sizes were very small. So I think that that's one of the things that we do want to include more sites in the Americas and in Asia that has endemic dengue would tell us whether there's cross-reactivity. But as far as I know, even in the SARS outbreak in 2003, there wasn't any real significant cross-reactivity of coronaviruses with dengue, which is another family of flaviviruses. Over.
Thank you. All right. There is another question from, she just wants to confirm if the evaluations, Jillian, of all those RDTs was done on the same samples. I guess you just clarify where that data is coming from.
So the COVID-19 Diagnostics project website, those data are all on the same samples, so you can compare that data head to head. I think the data that the FDA is generating with the National Cancer Institute, some of the samples will be the same across all the different tests. And then the performance evaluations that we're doing, because we're doing multiple sites, we will have different samples across the different sites, though we are planning to use a reference panel across every site so that we can compare some of the results head to head.
Thank you. I'll take possibly one of the last few questions, and it's from Bishnu from Nepal. He greets everybody, and he says they have 102 COVID-19 positive cases in Nepal. There is no single fatality case. Clinically, majority were asymptomatic, I guess, facing, I think, traces to detect coronavirus in the community. But his question is around pooling. I'm not so sure whether it means around molecular testing or for RDTs. How about pooling the tests? Is it reliable?
Jillian, you want to answer that? I only know of one pooling study that had been published, and it's not for. I think it says that it works well. It's for RDTs, but I know from using pooling for HIV, seroprevalence studies, etc., you have to be very, very careful, and it depends on the prevalence of the infection in your community. So it only, you could actually calculate how effective pooling can be and how big a pooling size, a pool needs to be. In that particular publication that I read, it was a pooling 30 samples together, and then being able to, they validated that they were able to detect all the positives within that sample, within those specimens, by pooling 30 samples in one pool. And they said that it saves reagents, not necessarily saving time, because it's quite, the extraction procedures you have to done sample by sample anyway. But it saves reagents in terms of doing the actual RT-PCR. And depending on how many pools test positive, then you break out the pool and test each member of the pool individually.
Thank you, Rosanna. Yeah, I think as we get to the end, I just want to acknowledge that we have seen the requests for slides in the chat box. And as usual, we will share the slides with at least everyone who joined the session today, and then later on with the rest of ASLM members who are on our list save. So we also encourage you to join our membership. There are also requests for certificates for attending this. We are working on this, and we have been tracking, I think, all your attendances. So we shall be working on that and getting back to you. On your screens is also a poll to just give us feedback on how you found this session today. And I hope you found it very valuable. Please let us know what your feeling is. Just in 30 seconds, let me ask Jillian to just give a few remarks.
Sure. Thank you all for joining. And I think it's clear that we need to take into consideration all of the data available with the fact that this is a new virus, and we have to make decisions quickly. So I think Professor Peeling very nicely explained how you can go about verifying products for use in your own settings, as well as the need to consider the prevalence in the population that you want to test. And stay tuned for more evaluation results from us as well as others.
Thank you, Jillian. Professor Peeling, 30 seconds.
Yes, thank you very much, Nafi. And I really like to thank ASLM for giving us this opportunity to share with you what we know about coronaviruses. and how to measure test performance, which is a huge topic right now, because diagnostic tests are a critical component of the control strategy for the pandemic. And so please let us know if you have more questions, and we hope that we will be able to answer them and answer them better as we get to know the bug better. So thank you.
Thank you, Rosanna. Thank you, Jillian, for the two wonderful presentations and sharing the information. And most importantly, thank you to all of you who came from all corners of the world. We appreciate you taking time. And for me, what is left is to say goodbye and see you next week.